My topic is on bucket-handled meniscus tears. And as we all know, it's one of the most common and one of the most challenging conditions when we do an ACL reconstruction along with bucket-handled repairs, because they take a lot of time. And these are mostly incidents around 10 to 26% of all tears. And the bucket-handled medial meniscus are quite common in compared to the lateral hand meniscus. So how do we diagnose? This patient also comes with pain. Most commonly, they will say the complaint of locking, and the McMurray will be more tenderness. In the MRI, you will see a double PCL sign with subcondylar edema. So when to operate? So basically, in acute cases, yes, we need to operate it, or a patient who presents with locking is better to go ahead and operate this type of patients. So then comes, how do you determine what's the pattern of tear or the extent of the tear? So if you divide the meniscus, we need to see on intra-op, it's the posterior third, middle third, and the anterior third. So whenever we write, we have to understand it goes from posterior third to the middle third or the anterior third. Now preparation of the bed, yes, we need to use a diamond rasper or a saver blade, sometimes with the help of needle. In many of the paper, it has shown that even though a basic, the needles which we pass, the meniscus needle itself creates some types of bleeding which helps in meniscus healing. The fall of the meniscus before you reduce it is very essential. So you need to look for it so that it properly places back to its normal anatomical position. So type of fixation, yes, the anterior third to middle third is better to go for an outside in, and the middle third to posterior third is better to go for an inside out, and the posterior third is always you should go for an all inside. Incision, whether to give vertical stitch or horizontal stitch, we all have our own way. Implant used, yes, we have the navigation things. And intra-op difficulties, one of the most is the joint space is very less, so you need to do pike resting. The re-rupture of the knots, so you have to be very careful while passing your needles and loosening of the stitches. So once you pass it, intra-articular, try to see how your fixation it, and then go for a thorough checkup. So this is a case of a bucket handle medial meniscus tear in case of a football player. As you could see, when I flexing the knee, the meniscus or the bucket handle tear is already has come out in the intercondyle notch. So I fixed it in this position. I took 2 bites on the anterior horn from outside in technique, so that this is before reducing it. So I could take 2 bites in the anterior repair on the anterior horns, and I could. Mostly it's like one on the capsule side, one to the intermeniscus body, so that it gives me a good purchase. Once I get these 2 purchase in the anterior horn, then I slowly reduced the meniscus towards its normal anatomical position, and then once the meniscus is repositioned, I use the inside out technique with the help of meniscus needles. Like I generally go for horizontal stitches to try to get the maximum purchase I can get, and followed by between the 2 horizontal stitches, I take a vertical stitch. And later on, the posterior third, I always repair with an all inside technique, so that it helps. This is what inside complete all inside technique. Another example, this is a case of a rugby player. Here the pattern of tear was slightly different. It was case of a chronic complex bucket handle medial meniscus tear with ACL tear. The anterior third insufficiency was that it was slightly torn, and if you see it is a very friable amount of tissue, just go back. Yes, do I need to save it or just resect it? But I went ahead and repaired the meniscus. I used 3 stitches, all inside out, and then later on the thin friable repair of the posterior third with inside out. The maximum, you should always go for the maximum you can go, and you should, while passing the needle, always check the posterior compartment of the knee, so that you don't go very posterior or you might puncture the neurovascular structures. And once you do this, you take the incision, secure the knots, look for it that you're there, and later on go ahead with the all inside anchors. There is another case which I'd like to show. It's an IT professional. It is very difficult. It's an irreducible bucket-handled medial meniscus tear. Yes, sometimes it's challenging. You feel like, okay, let me resect it, it's an old. But you, before doing this, just try to take a stay suture, aim for the middlemost thing. We have tried multiple attempts. So I took a stay suture to pull or hold the meniscus back. Once I got this, and I tried, then once my needles were there, the sutures were hold properly in the middle of the meniscus, and I pulled it. Yes, I took it inside so that I can get it. So now it went back to its normal position. So I don't have any stress. Now I could understand where exactly I need to press. So I started preparing the bed with the rasper, or you can use the shaver blade, whichever is you have with you, and then fix it again with the help of inside out. Sometimes the patient is not affordable, so we have, you need to reuse the needles. So this is where we have to look for the knots. So the knots you always try to, under observation, try to bring it through out of the capsules. Sometimes they open out, but again, if you are not able to bring the knot out of the capsule, keep it at least at the capsular side, not on the meniscus side, because it might impinge. So after giving the second stitch, you go again with the all inside technique. So this is a vertical stitch in which I put a T pattern between the two horizontal stitch. I take a vertical stitch. So if I have got 3 horizontal stitch, there will be 2 vertical stitch which holds like a clamp. So this is another 24th cases of a badminton player, bucket handle ACL with meniscus. It's a small, large posterior third. Again, after rasping the meniscus, you again use with the help of the meniscus needle. Another technique which I would say, when you pass your needle, get some bite of the body of the meniscus and then pass the needle so that it doesn't move here and there when you pass your sutures. So these are the vertical stitches which you take for the meniscus capsular, and once you get it, it's all the same for all the bucket handle middle meniscus. So basically aim for the middle third of the meniscus first and then go posteriorly, and at last, if there is some anterior third tears, you can repair it with the outside in technique. So few of the FAQs which I say, which are to operate as a joint preserving surgeon, try to repair all the meniscus. Chronic tear, repair not, yes, you better try to repair it if it is repairable. Diamond rasper or not, yes, we can use a diamond rasper or not. If you don't have it, use your shaver blade or the meniscus needle or an 18 gauge needle or the spinal needle we have. Number of suture threads is completely up to you how good the fixation you want. So take home message, a proper clinical examination is must. The double PCL sign in the MRI. Keep your hand instruments and kit ready. Minimum 3 to 4 stitches are essential. A combination of vertical and horizontal stitches are well acceptable. And tie the knot, always tie the knot under vision when you take a safety knot or a safety cut. And probe the repaired meniscus and check the RM at last before you move out of the OT.